There you guys go.
Hey, you do it.
Yeah.
It's better just to sit up, you know. Ooh.
Nah, usually when Dr. Knight is around, we do both push-ups and sit-ups. We gotta do 100
Dr. Knight
each.
would be happy right now.
You would.
Dr.
This
Knight
man's
taught
using
me
all
this one.
core back there.
Yeah, he taught me this one.
I'm not sure exactly what Randy's doing, but
Yeah, no, he taught me this. It's about using,
Yeah,
the glutes.
Dr. Knight does it a lot.
Yeah, you have to activate the glutes and the calves at the same time. Look at me go. Took months of practice. Oh, there you go! Quick learner!
Yeah,
Quick
I'm
learner!
learning. I learn by doing.
It's not what she said.
Oh, he's going over there. Get those
Looks
sit-ups
like
going. I think we're pretty limber here.
just about everybody's here.
Don't mind me, just working on my squats.
There you go.
Thorn to Chemo. Will you be attending the class over at the new hospital?
Russian twists.
Affirmative, yeah.
Jay!
546 1041.
Hi!
By the way, somebody's lights are on outside on the ambulance. I don't want you
Oh,
guys to run
God.
out of gas.
Is that me? Is that me? No, that's not me. I wouldn't do that. Just
Wait.
kidding.
What happened to this door?
They're
Trying
locked.
to get in the line here.
Yes, sometimes that happens. It's one of the few issues.
Just a bunch of dudes getting after it.
You need a door?
Weird.
They have doors.
There's not a door right
we're
just
all
like this right
dudes.
here. There's no door
Just
right
a
here for me.
bunch of dudes.
There's no door right there for you?
You guys limbered up or what?
There is no door.
what's up? What are we?
I see a door here.
We're just bored, so like we're just checking out what's going on with like 200 EMS trackers here. So like, what's going on with this?
Working on their squat.
Oh yeah, bring it.
Limber up. Limber
Come
up,
on, Jake,
everyone.
Come on.
Bees, go.
There we go. There we go. You got some of this? Yeah, here it is. There it is. Oh, good form.
Ooh, Thorn.
Yes.
Yep. Yes,
Yes.
no, I can.
This guy's hitting some Russian twists over there.
Pink jacks, let's go. 1, 2, 3. I'm tired. Yeesh.
You're definitely working EMS.
4, 5, 6. All right,
Yoga
I'm down.
time.
Hey, you know, you gotta pace yourself. Just pace
Yoga
yourself.
burger.
That's real.
Yoga burger.
There's like
Oh
nearly
my god, she's reached the advanced form.
There's nearly as much EMS as there is fucking PD on the air.
That was hilarious. Mike, are you good?
Hi,
Well, like
Mike.
that
Went
weird
right-
flex, bro. Whatever.
Kind of ran right through you.
Yeah,
Whatever,
right
bro.
through me, yeah.
Did somebody
that's the
say
wrong one.
yoga sandwiches?
Yes.
Limbering up. Limbering it up.
Flexing that
This guy going
urethra
back?
move.
Let's get. Let's get.
Let's
He
go.
just did a backflip into a twerk.
Bernie.
That is impressive.
What?
Hey,
I don't get what's so funny.
Bernie and Jay, y'all need to chill out here.
Is this like an EMS joke?
What
Guys?
are you talking about?
Is this like an EMS joke?
I think you need to chill up.
Thorin, I
No.
missed you.
I missed myself.
Gotta
Okay.
relax the mind
passive
and the
aggressive.
body.
All right.
Yes. Who's
Drink
father?
the water.
That's good, Hall.
Who's
What's
father?
good?
And now time for a sandwich.
Marty, are we like not getting anything here? Like, I'm confused.
All right.
This is what we do every Saturday at this time.
Mike, you
3
ready?
3 p.m. Central Time.
Are we missing anybody? Or is everyone here?
You guys
I
have like
think
a
we're missing
massive
Chemo,
session
but
with
he's here
every
now.
EMS here.
Yeah, he just
Yes. Yes, we all just come here and stretch for rituals.
All
It's
right,
good
listen
stretching.
up.
Stretch it up.
Listen
Where'd
up.
Raphael go?
Stretch
What?
it.
Class is in session.
Shut up. Wow, it's impressed.
Form into ranks. Form into ranks. and have a
Okay.
seat.
Yes. Okay.
It's like an
ready.
Indian circle.
Okay.
Sure, yeah, I mean,
Oh,
whatever.
yeah.
We can do a circle, or
Why
we
you
can do
taking a
lines.
picture,
It doesn't
kid?
matter. Whatever
No,
geometric.
we're doing lines.
Shut
I
though.
was gonna, I was gonna,
Octagon.
Okay.
I'm beginning the
Octagon.
circle.
It's my favorite geometric
There we
shape.
go. Circle it is. I like this. Yep. We're almost there. You guys remember what circles look like from kindergarten? I hope.
Not necessarily.
That's
No.
the
I-
listen
linear
here,
three-sided
listen
thing,
here.
right?
I missed
My-
that day in
Thorn.
kindergarten.
My advanced
Listen
degree
here,
tells me that
Santa.
circles aren't real.
Oh.
All right, we're playing Duck Duck Goose.
Think, meditate, and then notepad.
No one's check. Don't look
There
at
we
my
go.
notes.
Meditate circle.
Now we look like a real circle.
Oh.
Right, Duck Duck Goose, go.
Nope.
Yeah,
We're a
I
little bit
use
more
my-
professional than that.
I use my leg just to make sure I have
Hang
a
on.
thing to write on.
Thorin, can you just speak up just a little bit? I can't really hear you over here.
Yeah. How's that?
Thank you.
Okay.
Good.
This is like a
Alright.
group therapy
Now it's
session.
yelling.
It is.
Well,
Yelling.
I'm okay with that,
Sort
though.
of,
Because
yeah.
I can go off at some things.
What we doing?
All right,
Marty
Mike.
here,
You
I think.
wanna
Alright.
you wanna stand up and introduce yourself in the middle of the circle here?
Yeah, go ahead.
Hi, I'm Mike. I was abused by Marty.
We see you, Mike. We see
No,
you.
no, no. You were abused by me, and that's why you went to go see Marty.
I enjoyed that part.
Oh, okay.
Oh.
All right, so everyone, outside the city, I've been in EMS for 20 years. I've been a
Yeah.
paramedic
Holy
for
fuck.
11. Yeah, I turn 40 next month.
Thank you for your
No.
service.
Oh my
Yeah.
god.
Yep.
Thank you. We
And
love
thank you
you.
for your service, my man.
So
Yeah.
Hell yeah.
Sure.
I wanted to put these classes on to give a little more in depth of what's going on and what we really do and why we're doing it, to help with the role play aspect of why we're here in the game.
The rolling
what?
papers. The
Yes.
rolling
My
papers.
Rolling
fucking
papers.
immersion, dude.
Yeah.
The
Yes.
rolling papers.
Dude.
Yeah.
Not quoted.
You can't
What
say rolling
he's
papers.
saying-
PD's right there.
The
What
roasted
he's saying
potatoes.
is he's
I'm
trying to
kidding, I'm
make
kidding.
sure that we serve the citizens
It's
of
legal
Los
so
Santos
long as we have only
much
5
better.
rolling papers. Excuse me.
The
I
PD can't
understood what he
count.
said, dude. Wait, what's going on?
So I figured I'd start with today.
Fine.
We go over oxygen delivery, CPR,
The thing is,
cardiac
uh,
rhythms,
radio,
fuck
bro.
that, who
uh,
cares?
Should we
shocking
turn that radio
somebody,
off? We should turn the
and
radio
some
off.
medications. Basic medications we
Yeah,
use
that's,
in
uh,
cardiac
good to know.
events. And then we'll have some questions, and then I think the next class, if we want to have one, would be over all geared towards trauma.
All right. Lay it
All
on
right.
his mic.
So, oxygen delivery. We have a bunch of methods the way we can give oxygen to a person. If they're able to talk, we'd give them a nasal cannula. We kind of give that low flow, 4 to 6 liters. Not that you really care about that, but that's just to help supplement their normal breathing. If we have to give them a little more, we're going to give them a non-rebreather mask. So it's a mask with a reservoir bag that we're going to put over their face. And this is me, someone who has difficulty breathing, really starting to struggle a little bit. And then if we're doing CPR, we're going to use a bag valve mask, a BVM, which is exactly what it is. It's a bag that fills with oxygen, and we squeeze it and we force it into their lungs. So we do this. When we're doing this, we would actually put in a device to help us get the air into the patient's lungs and not their stomach. So we can either stick a nasal pharyngeal airway or an NPA in, or an OPA in the mouth. But the easiest thing to do is to intubate somebody. So we want to direct that oxygen directly to the lungs, or else you're going to get a shower. Air will go right into the stomach. It will expand like you would never believe, and you will have a fountain,
A vomit?
a fountain of puke. So I would use these devices to keep the air into the lungs, not the stomach. So we're doing CPR because someone isn't breathing / doesn't have a heartbeat. So what first we're gonna do is we're gonna go up and look, listen, feel, like we're just taking a CPR class. We're gonna check the person. We're gonna shake the person, ask them if they're okay, and then we're gonna go in, and if they're not breathing, and if you don't feel a pulse, we're gonna go in and start doing compressions. We're actually going to force blood through the body. We're gonna take the place of the heart. This is important. We need to keep the main 2 organs in our body, the brain and the heart, fed with oxygen. CPR is probably going to be changing as we know it in the next 3 to 5 years. The success rates in the real world, outside the city, for doing CPR on somebody with sudden cardiac arrest in the United States is 3%. 3% of the people will walk out of the hospital. Japan, it's 10%. So, and there's actually 2 counties down in Florida that are actually piloting a new CPR for the Red Cross and the American Heart Association, and they're starting to get up into the 8-9%. So it's good news, but for a world that's so advanced as ours, that if you have sudden cardiac arrest, your chances are you're going to die. So
technically already dead.
The main object is to keep the heart pumping blood through the body to the 2 main organs. We do this, and we do 30 compressions, and then we start doing 2 breaths. It used to be, if you've ever taken CPR before, you would have heard 15 and 2. Well, the heart is a pump. So really, they found by the time we got the pump primed and to start actually pushing blood through the body, we were stopping. So now we're actually doing a little bit longer, so that way the blood can actually circulate. There's a dog outside. To the body.
For in a hospital, or rather a pre-hospital setting, PS guys, by the way, in case you don't know me, Thorn Blackfield, out of state. I was an EMT. It's been expired for quite a while now, but I was an EMT firefighter out of the state for quite a long time, for 2 years straight, and continued using that certification as a corrections officer outside of the state for a number of years, and currently work in a hospital for about 6 years out of the state. So
Yeah.
in a pre-hospital
I
setting,
do not know any of these in real life. No.
you ventilate the patient with a bag valve mask.
They are deciding to do
about every 5 seconds.
CPR
okay, so if
class.
we have 2 people, if Mike and I show up on a scene,
Well, not just
and we've already put a
CPR,
bag valve
but,
mask on the patient, it's constant compressions,
a training
okay,
class.
and a bag valve ventilation every
Drop
5
everybody.
seconds, okay. But if it's just one of you on scene, which is, let's be honest here, that's most of the time, right? Most of us we ride solo. It's 30 and 2, okay.
Inside the hospital.
We're trying to get Connor to
Fucking
buy
go.
us the
10-9?
compression devices, but they're about 30K.
Sorry. Sorry.
Lucas is on
Nice
You're
trip.
fine.
See you next fall. So, as we're doing this, the main goal is 1, to get him to the hospital, and then 2, we would put a monitor or AED, depending on where you're at, onto the patient as quick as possible. Contrary to tacos. Hi, Taco.
Taco.
So
You're late.
yeah,
This will be recorded. We were told. So we're all good.
Yeah.
so when we put the monitor on or
It's
the
still
AED,
recorded.
we're actually trying to check the heart rate and the rhythm, because we're looking for 2 main rhythms that the AED is going to work for. So it's only going to work for VFib, ventricular fibrillation, and pulses VTAC, where the heart is just beating so fast that it cannot fill with blood, so it
And right now
can't
there's
pump
currently
the
no
blood to
EMS
the body.
in the city.
That makes sense. VFib,
Which is nice.
actually your heart is about the size of your fist. So imagine your fist
Oh my God.
is just a bunch of worms just wiggling around. That is exactly what VFib looks like. Your heart can make electricity, and any part of your heart can get irritated and fire off.
This is true.
And actually cause a beat. So it relies on the internal pacemaker, the SA node, to be the band leader and tell it what to do. But in this case, it's not listening. I teach students, imagine it like you're at a party and everything's going great, heart's beating perfect. People get drinking, having a good time, a fight breaks out. It just turns into chaos. So we're using that electricity from the AED or monitor to stop the heart. We're not trying to start it because everyone says, oh, we're going to jumpstart the heart. We're actually stopping the heart. The goal is to stop it and hopefully that the pacemaker can regain dominance and start getting the heart back together. So at the party's going on, a fight breaks out, turns into chaos. You call the police. Police come in, take the troublemaker out. And then the band starts going again, and everything starts going back to normal. So the AED only works for 2 rhythms. And then the other rhythm I really wanted to go over is asystole. Right?
Which
no
is
heartbeat.
nothing.
There is no electrical activity going on in the heart. So this is mainly
He just forces his way
where you need drugs, right? Drugs and the CPR. The CPR will keep the person and their organs going and alive. The drugs are what is going to save the person and bring them back.
Like epinephrine.
So in this situation, we call it a code. We use one main drug, right? Epinephrine. Epinephrine comes in multiple doses. We use epinephrine 1 milligram, and we give it IV. And the hope is to get that heart and that activity going again in the heart, to get some kind of rhythm that we can do something with. If you watch TV, and you see the different shows, the only thing they get right is when they shock somebody, the person will actually contract, right? It's electricity going through the body, muscles will contract. That's the only good thing, the only thing that TV gets right. So we're going to give that epinephrine every 5 minutes to try to get some activity back into that heart. If it starts going and gives us any rhythm, then we can work with it and try. Any questions so far?
Crickets.
All right. That's either really good or really bad.
Afterwards.
Yeah, I'm gonna have to go back and rewatch. I think.
Yeah.
Outdoor
I'm
Dive.
trying to really keep it at a low level for everyone, but at the same time try to get with some
No,
detail.
Mike, you're doing great. I just for my notes that I'm taking, I want to make sure I get everything.
Yeah,
So-
I'm gonna drop my notepad after this, and I'm gonna have you comb through it with a fine tooth comb and make edits
All right.
where needed.
So there's another couple rhythms I really wanted to go over because we see a lot of slow heartbeats, right? That's sinus bradycardia, that it's just going slow. And you gotta look and kind of see what's going on. Why is it low? Do they lose blood? Is there low blood volume, right? Is there not enough blood to circulate through the body? Or is it just something going on in the heart where we can give a medication to up the heart rate? So we have a medication called atropine that will speed up the heart. And then there's a drug called adenosine, which will stop the heart, which is freaking cool, by the way. So atropine goes up, adenosine goes down. So one has a P in it. the one with the D goes down. I could give the spellings afterwards for you if you wanted.
Okay, yeah.
So we give this medication, and you can also use the monitor, our cardiac monitors we have in the ambulance or the hospital. Sorry, my kid in my head. To pace a patient. So if they're not responding to the drugs or our fluid that we're going to give them in an IV, we can actually put the pads on them, and we can do a specialized shock to them, very low voltage, and we can then increase their heart rate with electricity. And if chances are, if we're doing this, they're going to need a pacemaker in. They'll be going to a cardiologist and getting a pacemaker.
Oh my god.
Is that a whole bunch of people back there? I don't know.
Everybody has to show their notes at the end. Just kidding.
Bring it on, my
I don't really
brothers.
have notes.
Got her.
You guys are writing
I'm gonna
like
be honest. I was drawing
shit.
pictures.
And that's fine.
I'm more of an audio.
I do this every day in my
I
head.
can-
I was just gonna steal somebody's notes.
We can
Sounds
just make
accurate.
a Google Doc.
Audio and visual.
Yeah, where's your poster board with pictures?
And I'll go over one other heart rhythm. I really wasn't planning on going over it, but it's kind of cool. So it's SVT, supraventricular tachycardia. This is when the heart beats above 180 beats a minute. I've seen it go as fast as 320. So the heart is just beating so fast that, for just unknown reasons, right? It could just start.
It's beating above what now?
180. Yep.
Okay, thank you.
It's the textbook definition.
It's called SVT.
Oh shit.
The highest I ever got was 290 on the 15.
Yeah. And what we're gonna do is, if they're really starting to give us signs and symptoms of poor perfusion, if they're confused, their chest hurts, they're having difficulty breathing, then we're gonna go in right to electricity, and we're gonna do a specialized shock, and we're gonna make sure that we call it cardioversion, synchronized cardioversion. We're gonna shock the heart at a specific time to make sure we kind of reset it. Because if you shock the heart at any time, you're just going to stop everything. So we're looking for a specific time in that heartbeat where we're going to shock it. And we're going to keep doing that until the heart goes back to normal. Or we have the medication adenosine, and you can actually, you have to push this as fast as you can in your IV, because it's pure energy for the heart. Adenosine is part of the energy of the heart, what it makes out of your body. And it will actually stop the heart. And if you're looking at this on a monitor, you can actually see heartbeats, and then it goes into asystole for about 3 to 5 seconds. And this is the longest 3 to 5 seconds of your life.
Asystole is what most people call a flat line, by the way, on the monitor. It literally looks like a flat line.
It is the scariest thing, because they tell you it's going to start back up again, but you're praying it does. And it is this, and it's literally like 3 seconds, but it will feel like an hour.
Oh my god.
And we do this up to 3 times. And we're trying to get that heart back down to a rhythm where it can start pushing blood to the body and causing perfusion to the brain and to the other muscles and organs of our body.
Okay, drawing.
So when we are going to shock somebody, with the AED or monitor, we want to make sure everyone is clear, because we're going to be stopping the heart of the person that we are taking care of, our patient. If somebody else is touching that patient, you will stop their heart as well. It's very... I'll put a link to a YouTube video in the general, and you will see it. It is crazy. 2 paramedics lost their job over it. On the video I'll show you. You need to make sure everyone's clear. I made a student call my wife and tell her that she killed me in a training session because he wasn't paying attention to who he was shocking. So it's just, you make sure everyone's clear so you don't kill anybody. That's the big thing.
Exactly.
Any questions?
What was the asystole thing that you were talking about a second ago?
Asystoles?
Asystole?
Asystole is a flat line.
Yep.
Okay.
0 electrical activity in the heart.
Mm-hmm. So, real quick, Mike, remind us what shockable rhythms are.
That would be VFib and pulseless VTAC.
Right. So VTAC and VFib are shockable. That means the
anything with a
AED
V.
works on only those rhythms. Everything else will not work. So it's very unlikely that you're going to run into a patient who understands this, but do understand that it is a thing that happens, and we can enhance our interactions with the patients of Los Santos by incorporating these types of things into our interactions with them. So VTAC and VFib.
I have a question then.
Shoot.
If we're saying that, as part of our training going forward, being able to use essentially AED or shockable pulses on the VFib and the pulse VTAC, you mentioned specifically that there's a sort of specialized shock that you can do with also the low heart rhythm and the SVTs. Is that something that is only specifically done, for example, in a hospital setting and not something where it's just in transport?
We do that. We do it all in transport.
Okay.
Yep, this is all pre-hospital.
This is all stuff before we even get into the doors of the hospital.
Okay. So in this case, then, for the people of Los Santos, we're only essentially mainly focusing on the VFib and the pulses attack? Unless it's a specific case that, unless it's specifically stated that there a low heart rhythm or SVT.
Right.
Okay.
And I wanted to give the other ones so everyone can just have a better knowledge.
Okay.
What's going on? That's all.
Thank you.
And you might have to ask them if they mean flatline.
Of course.
Yeah. That's the big one. That's one everyone knows. Everyone kind of knows the other ones because they, everyone watches TV. So, any questions? Any other questions? Thorin, would you like to go over anything?
I would. There's quite a bit I'd like to go over, but you guys have all been great, and I don't want to keep you here too long. I do want to cover a couple things that will, I think, enhance sort of our interactions with the citizens of Los Santos. I don't think I've ever run a medical call here. That is something that I think we'll have to speak with the governor about to encourage people to have medical calls and medical emergencies. But with that said, most of us do not have any prior out-of-state training or experience, and so we kind of just wing any sort of medical complaints we get. With that said, I do want to talk briefly, very briefly, about trauma patients and trauma assessments, kind of what it looks like when you get on scene. This is a really lengthy topic that could take, hours, to cover correctly, but I want to make it very, very quick. When you arrive on scene, as with every scene, period, point blank period, your primary concern is BSI, which is body substance isolation, or PPE, so gloves, mask, gown if necessary, face shield if necessary, SCBA if necessary, et cetera, right? All these different things that keep us safe. So PPE, BSI, these terms are interchangeable. So BSI and scene safety. Are there down power lines? Are we in the middle of a road? Is there a fire? Right? Are there actively gunshots across the road? We need to be careful about these things. So we're number one. Everybody else comes next. You guys all have the handbook, which covers the order of life priority, so we don't need to go over that. But BSI scene safety, that's every single scene. We get up to the patient. Let's be honest, 95% of our patients are at least responsive, which is a good thing for us. However, I do want to cover briefly how to assess a patient who is not responsive. We use a thing called AVPU. That's AVPU, AVPU.
Alert, verbal.
In order,
pain,
this is the beauty of this little acronym.
and
In order,
unresponsive.
AVPU is basically the best to the oh shit. Okay, so A, alert. This patient is alert, meaning they can speak to you. They're sometimes up walking around. Maybe they're disoriented. It doesn't really matter. We're not assessing orientation just yet. We're just seeing how with it they are. Are they alert? Are they paying attention? Second is verbal. Do they respond to verbal commands? If for example, let's say Mike is laying down here, looking kind of groggy, not responding. As I walk up, hey Mike, Mike, hey, are you okay? Are you okay? And he just kind of, okay, great. We're getting a verbal response. Or I tell him I can do something called, I can say, hey, Mike, squeeze my finger, Mike, squeeze my finger,
I'm pulling your finger.
So let's say I do that. Let's say I do that, and he, I don't know, tries to raise his head. Okay, and I tell him again, Mike, hey, squeeze my fingers, man. And he again tries to, stick his tongue out or something. This is called an inappropriate response. So inappropriate, that's another key word, okay? But if I tell him to do something and he complies or he responds in any way, even inappropriately, we have a verbal response, okay? P, physical. This is where Mike is laying down and I flick him in the eyeball. Don't do that. That's unethical. But I can do something called a trapezius pinch. This is where I pinch Mike right up by the base of his neck, and it hurts. I can also rub his sternum, which is called a sternal rub. Let me write that down and show you guys how that's spelled.
And you can really grind your knuckles into their chest.
Your goal should be to bruise them. You want to make sure that they feel you. Okay. Now listen, in the hospital out of state that I work at, they call me for the sternal rubs because I'm good at them. I've got numerous patients. I do have good hands. Don't tell the ladies of the city.
All
so
right.
You really want to get in there and you want to make sure that patient feels what you're doing. Here's
Put
what
a tweet out for
typically
all the
happens.
guys. Warren's got good hands.
What you should be doing is thinking of putting your knuckles into their chest and rubbing hard. Okay.
Right on the breastbone.
Right on, literally, right on the breastbone. For ladies who have larger chests, make room and get in there on that bone.
Get in there. Dive in there.
Yeah, dive right on in.
Okay.
So typically what that looks like is a patient who is maybe stuporous or unresponsive. You're trying everything. You're shaking them. You're kind of slapping them a little bit. And they're not responding to anything. You do that sternal rub, and typically what they'll do is they'll jolt awake and then go right back to sleep. But that's okay. It's okay that they go unresponsive again because you know that they're responsive to painful. Okay? So AVPU, U is unresponsive. I've done everything. This patient is not responding. These are the points you go back to the ABCs, airway, breathing, circulation. You need to make sure your patient's still got a pulse, is still breathing. Okay? So, Jay, what is the V in AVPU? Verbal, right.
Sorry about that.
Verbal stimuli, verbal response. Okay? So we show up to the scene of a wreck and we assess the patient. Are they talking to us? Great. We already have our A. Check. Now what we do is we start from the head, okay, and we work our way down the body and assess for what's called decap BTLS.
Deformities, crepitus.
Spelled like that. Okay? Decap BTLS. It's deformities, contusions, abrasions.
Can you go a little slower on that? Slower on that?
Of course.
Thank you. So, deformities, contusions.
Abrasions.
Thank you.
Penetrations. Burns.
Tenderness.
Tenderness.
Lacerations and swelling.
Lacerations. And swelling.
Thank you.
Now, some places will teach you, and I disagree with it, but some places will teach you that it's... I'll write down a notepad and show you guys. Some places will show you like this. The E in that is for evisceration. That is literally where the stomach is what's it called? It's not the pleural lining. It's the lining of the abdominal cavity, which basically is all the organs in the stomach are in a
out
sac.
of the body.
And yeah, that sac is broken.
Your
and they
intestines are
literally
out of your
come out.
body.
Yep. That is an evisceration.
Or the skin, like a degloving, where the skin is just been ripped away.
Right. It is a thing. It happens.
Love it.
Thank you. Peritoneal. Yep. Thank you.
Yep.
Thank you. Yeah, the peritoneal lining. Yep. By the way, there's a fluid in that lining which stinks when you smell it. So that's just an aside. It's kind of a yellowish fluid. Just throwing it out there. Seen it, smelled it. It's gross. Okay.
Take me back to biology. Oh, thank you.
Decap BTLS. Decap BTLS. So I start at Mike's head. I assess this patient. Mike, can you hear me? Can you hear me? Okay, we have a verbal response, right? Not a great one, but we know he's talking. Hey, this is paramedic Blackfield. What happened? Can you
Not
even
pulling
respond?
your finger.
Can we even respond? Can you tell me what happened, Mike?
I don't know. I just fell here.
Okay, he doesn't know. So
Mike.
we know he fell. Okay, so maybe we see a car, maybe we see a tree, whatever, right? Maybe a local saw what happened. We start at his head. Hey, Mike. So if there's two of us, I'm going to hold C-spine, which is literally where I put my hands at the base of Mike's neck. And P.S. By the way, guys, as an aside, please use the following. I'm gonna write it on a note so you all can see it. Please use the following to enhance your interactions with the patients in the city. It is a fantastic tool that nobody uses. And it looks like this. And there's none of that bouncing up or anything like that. So, okay, Mike, you fell. Okay, so we're going to hold C-spine if I have somebody else. Or maybe, maybe somebody else shows up or I call for backup. If I don't have somebody else, I use a C-collar, okay? Always remind the patient that the C-collar will not stop you from moving your neck, but it will remind you not to move your neck. Don't move it side to side. So I say, Mike, don't move your neck. I'm going to put the C-collar on you. And stay looking forward, okay? And I'm going to start, before I apply that C-collar, I'm going to swipe his neck. I'm feeling for blood. I'm assessing that decap BTLS, right? Do I have any anywhere on the skull that's soft or wet where it ought not be? And I work my way down his body. Yeah, hey, bud, we're about to get to the dirty parts. I'm working all the way down his body. I'm assessing his ribs. I'm checking for what's called crepitus, which is a instability of the ribs, which is it feels kind of like a Rice Krispies feeling.
I'm never gonna have a Rice Krispie again.
You can feel that in other bones as well too.
I had
Yeah,
one for
you
lunch
can.
at the city.
You can indeed.
It's
feel
very
that.
common in arm injuries. And
Yes,
leg
it's
injuries.
very common. Yeah, very common in arms and legs. It's a grinding sort of Rice Krispies feeling. Sometimes it's associated with the sound. So anyway, you start at the head and you work down.
really bad.
Genitals will skip over because you guys are children, and you just do that all the way down to the feet. Okay. At that point, you decide what it is you're going to do with this patient. Most of the time, in a pre-hospital setting, there's only so much you can do: bandage, splint, maybe some pain meds, and transport. Okay, so we're not there to cure the patient. We are there to get the.
We're all 10-6.
We're there to get them to the hospital safely and allow the doctors and nurses at the hospital to fix them up. Okay, so again, I want to recap very quickly. And Marty, you are the star student here. So, Marty, we arrive on scene. What is the first thing we assess? Or rather, we arrive on scene. Boom, we're on scene. What's the first thing?
You want to do a decap?
No.
Get fucked.
Bernie?
I'm sorry.
Okay, sorry, what was the question?
We arrived on scene. We get the call. We're at the scene. What's the first thing? What's our first concern?
Your first concern is your
Safety!
PPE.
PPE, BSI, scene safety, right.
Yep.
So we arrive to see the patient. Maybe he's down. Most of the time, let's be honest, 99.9% of the time, our patients are down, similar to the way Mike looks right now. What are we assessing? First thing, Bernie.
The surroundings, make sure there's nothing that could harm us. Still.
Sure. Scene safety. The scene is safe. We're now dealing with the patient. So what's the first thing we deal with?
The first thing we do is
Sting.
to check if they're alert. Talk to them, get their response.
That would be called assessing what, Mike?
Mentation.
Yep. Their mental
What was
status, their responsiveness, however you want to word it, but mental status. We want to assess the mental status. The very first thing, technically, if you want to go by a flow sheet, the very first thing we're doing is getting what's called a general impression. If Mike has a spike sticking out of his chest, we know exactly what happened. Okay, so we have a general impression from the moment we see him. Or maybe we see Mike doubled over vomiting. We have a very good general impression of what is going on here. Mike is sick to his stomach, or Mike has a. So when, if any of you are interested, when you take boards, literally, here's exactly what it looks like. You get called, and you say, BSI, scene safety, and they say, okay, yeah, your scene's safe. And then you say, my general impression is this is
All this again.
mid-30s-year-old white male, lying face down, skin is warm, pink, and dry, or maybe it's not, maybe it's wet, who knows. I don't see any bleeding. So general impression is I have an unresponsive mid-30s white male. Does that make sense? So that's called your general impression. It's just it doesn't really apply so much in San Andreas, but that's technically first. So then again, we want to check the mental status, and then we move into what's called a focused assessment. Sometimes that's a medical, sometimes that's trauma. So we start head, work our way down. Okay.
All right.
Okay. I think that's it. I don't really think I have anything else. Do we have any questions?
Reminds me of National Registry all over again.
Oh my god, don't even go
I have
there.
a question for Mike.
What's up?
How does the floor feel?
Better now that Thorin is out of my comfort zone.
Well, here, Mike. Let me feel your ischial tuberosity, huh?
Oh no!
Let me feel your Rice Krispies.
Ew, Taco. No.
So seriously, I mean, look, you have
I'm
you have
trying
quite
to
a few
remove that
people
from my
here.
brain now.
Do we have any questions? Is there a call that maybe one of you have received that you're like, hey, this was a weird call and I didn't really know how to handle it? Is there something that we can educate you quickly on?
I got a quick question for you. So what if it's an elderly patient, they're underground, not responsive, and you're trying to apply the sternum rub? Like, if you're putting too much pressure down on them, you're going to crack some ribs because they're going to be brittle. If my understanding's correct.
That sternum is pretty tough, man.
You're only going to break ribs if you're doing CPR. And you'll break ribs on anyone.
Yeah.
It would be a adult, a 40-year-old, 20-year-old, you're going to break their ribs. If they used to teach it, if you're not breaking ribs, you're not doing good CPR.
Yep.
Yeah. So just this last, let me see, it would have been about 2 months ago, I had the opportunity to actually be the person who started CPR on a patient. I'd done it numerous times, but I finally got the opportunity to start it. And again, that feeling, that Rice Krispies feeling, that's exactly what it feels like and sounds like when you do it. You push down and it feels like Rice Krispies. So
subcutaneous emphysema.
You want to make sure, like, here's the thing. I was freaked out about it, right? I was freaked out about being the first one and breaking those ribs, but that's what it feels like. So yeah, but the point is, don't, and at the end of the day, so honestly, that's a really good question. And here's why I like it, because what you're saying, what I hear you saying is, I'm concerned about harming my patient. If you're trying to save a life, almost, I don't want to say everything, but almost anything is permitted if you can justify why you did it. Okay. If I took, so let's say Mike got in a car wreck and his spine is broken, he's paralyzed. I could 100% exacerbate all of his injuries by pulling him out of that vehicle. But sometimes I have to do it. Sometimes I just have to get him out of that vehicle. Maybe the car is on fire. I have to get him out of the vehicle, and me injuring him further is less of a concern than him dying because I didn't move him. Does that make sense? So it's a really good question, because what you're saying, life over limb, indeed. So what you're saying is, I don't want to hurt my patient, and that's a very noble thing, but sometimes we have to do it.
Thank you.
Of course. Anybody else?
And trust me, if you do CPR on somebody and you break their ribs and they live, they will thank you.
Oh yeah, no,
Oh, yeah.
CPR for sure. Like,
They will
breaking it.
thank you.
Yeah, 100%.
I have a patient who loves to seek drugs, and she'll fake a seizure. And it's to the point now where she hears my voice and her seizure will stop. You know she's getting a sternum rub.
Oh.
Yeah,
I will walk in. I will say three words. She knows it's me. She just stops.
Magic.
And she goes, her chest hurts for days afterwards. And that's...
So that should we cover vital signs real quick? What are the big six for vital signs? Since we have a diligent group here. Okay, so first things first. Blood sugar.
EMS.
Blood sugar is important on scene. It's not officially a vital sign, but it 100% is a vital sign when it comes to pre-hospital care. Okay.
All of EMS is in a training course right now.
Alright, it's a quick question. Are y'all missing a helicopter?
It could have been one that was scuffed earlier that someone got into, so maybe.
There's a helicopter here chilling inside. Do you want me to take care of it?
I try to. It's scuffed from the city.
Challenge accepted, thank you.
Sorry about that, Thorn. Go ahead.
No, it's okay. Who knows? Okay. So vital signs. Every single patient you interact with, I don't care who, literally even mental patients, okay? Every single patient gets their vital signs checked. Every single one. The vital signs are as follows. Blood pressure.
Pulse.
Pulse oximetry. Let me write that on the notepad.
Pulse and O2 stats.
Blood pressure, pulse oximetry, pain. I'm drawing a blank. Mike, help me out. Respirations.
Skin.
Yep.
Pupil.
And yep, pupils. Pearl.
The forgotten. Sign.
Okay. Oh, and temperature. Okay.
Oh yeah, since
nowadays.
Yeah,
nowadays it's temperature, especially nowadays. Okay, so blood pressure, temperature, blood sugar, skin, pupils, and respirations.
But if you're going to just remember three, pulse, blood pressure, respirations.
Pulse, blood, yeah. That honestly, those are the big ones.
Those are the three that everything else isn't needed. Those three are the main ones.
Yeah. So for your interactions with the city, let's just maybe focus on. So you roll up to a patient, maybe just blood pressure, pulse, breathing. Okay. But blood sugar is important too. Temperature is important too. Maybe a little bit more out of city than in city, but those are the big ones. Okay. Normal for just about anybody we should be dealing with is 120/80. And that's represented in millimeters mercury, MM capital HG. like that. Okay. So well, that didn't work. But anyway, it would look like that. What is the normal temperature, you, sir?
Of an individual is 97.8 or something like that.
Close.
Fahrenheit?
Very close. Very close. I'd be happy with a 98. I would be happy with a 98. I'm just being honest. 98.6.
98.6.
Yep.
And truly, after the pandemic, they're finding out that the actual body temperature is actually going to be lower, more in like 97, 9 area is the normal. But yes, 98. 98.6 is
98
the
is
book answer. But yes.
Yeah. 37 degrees Celsius for those of you that use Celsius. 37. Okay.
I use freedom units. Sorry.
That'll be one bald eagle, sir.
Yeah.
2 Matchbox cars, 1 bald eagle.
And a hamburger on the side.
So something fun to do, and I'll be honest with you guys, like this is the downside of being EMS. Most people here in the city just want to get back on their feet, okay? But I hope through courses like this that we can foster in people a sense of fulfilling interaction, if you catch my drift, fulfilling interaction using actual knowledge, okay? So if I roll up on Mike and say, hey, Mike, I'm gonna go ahead and check your pulse, and somehow casually drop to him that average pulse is like, 60 to 100, right? Just be able to, hey, I hope it's not above 100 or below 60, something like that. We can instill this knowledge into people in a organic way that isn't making them think that we're speaking to somebody that we're not speaking to, if you catch my drift.
Yeah.
So blood pressure, pulse, and breathing. Respiration. So I think this just changed, Mike. Maybe you can back me up on this. When I was in school, the teaching was 16 to 20 is normal for an adult, but I think they've modified that to be 14 to 20.
12 to 18.
There you go.
For an adult.
So,
yep.
Yeah, and that's per minute. So 12 respirators to 20 respirators, or 12 to 18 rather, per minute is good. Now, obviously, if they're outside of that, and I don't want to get into like actual patient assessments. Oh, we're going to assess for adequacy of respirations. Do we have good chest rise and fall? Or, do we have good chest rebound? We're not doing any of that stuff. But 12 to 20, 12 to 18, however you want to put it. So there's a good note for you guys. Okay?
That's a good test question.
Questions about that, guys? Anybody? The beauty of being pre-hospital is, especially not in a rural setting, right, where every transport we do is going to take maybe like 3 minutes, right? If something is like super out of whack, so say I take Mike's blood pressure and it's 190 over 110, I get to say, oh shit, that's not right. We're going to get you to the hospital faster now, right? And we get to sort of cut that interaction short. I don't have to do like a diagnosis pre-hospital. I'm not there to diagnose, but I get to acknowledge and use my knowledge to tell the patient, hey, look, there's only so much I can do for you here. Something is wrong with you. I'm going to get you to go see a doctor. And then let the patient lead that interaction, if that makes sense. Okay, so really though, any questions, guys? All right. So
I do have a basic question.
Sure.
And this is something that can easily be like looked up inside my head easy, but I just want to know what's the normal heart rate and everything, like basic normal body signs and everything.
So an adult, a healthy adult, is going to be 60 to 80. And really it's okay to 100. 100 is where we say sinus stops and sinus tachycardia starts. But a good healthy adult should be 60 to 80.
Yep. 60 to 80. 100, again, kind of okay. A lot of times you see like with white coat syndrome, so there's quite a bit of leeway there. I saw, more 100s than I care to count, and I was okay with it. I had no concerns about a cardiac arrhythmia or anything. So 60 to 100 is good. With somebody who's athletic, you might see it as low as 40, and that's okay. But 60 to 100 is about what you expect. 120 over 80, again, is the good number, but you can go 110. I personally run 110 over 70 is like my number. It's like 115 over 70. Yeah, I'm good, but I'm happy with my numbers. So 110 over 70 is about what I run. Nobody freaks out about it. However, I had a particular time that I went to the doctor. I was anxious. I didn't feel well. I was in pain. So understand that pain does increase blood pressure. Okay. I was nervous and anxious about my illness, and I was 140 over like 100 something. And obviously everybody's like, do you have high blood pressure? No, I don't. But that is, there is a little bit of leeway there. So if I saw 110 over 70 or 130 over 90, I'm not panicking, but I am going, what's going on here? It's when you start hitting like the 150s, 140s, 150s, that you start going, there's a problem. And certainly when you start seeing double digits on the systolic, then we have a problem.
Yeah.
Okay.
You can actually, it's high enough, you could start bleeding out of certain body parts. Like you can start bleeding out of your eyes.
Oh my god.
Yeah, if you get over like 200, you can actually start to capillaries in your eyes, blood will start leaking out of because there's so much pressure.
Yeah.
It just sounds uncomfortable more than anything.
It looked cool.
Oh no.
And then after like 5 seconds, you're like, oh shit, I better take care of him. I better do something for him because
my
he's having a
God.
hypertensive emergency.
Whoa, man. Bleeding out of your eyes.
What Mike is actually saying is he has Ebola, and this is an intervention. So, yeah, good question. Thank you for that. So, anybody feel like, oh shit, this is too much and I can't handle it, or need some extra TLC on this?
I may shoot you off some questions like in an email later on, but
Definitely.
as of right now, no. I feel like I'm good on this.
Okay. So another thing that you guys can use just on the reg, okay, like every patient you interact with, go ahead and start an IV. Now, the number one place to start an IV is called the anacubital fossa. Let me write that on a notepad for you guys.
Or you can cheat like me and write AC.
Yeah.
Yep. So that's AC or ACF. So you would literally, like, if you were typing or writing a narrative, you would literally write something like that, which would be write ACF. Okay. There are a number of gauges. I don't think any ambulance actually carries like 14 gauges, but they do exist.
Yeah, we all carry it. Yeah, 14 is trauma.
Yep.
Maybe putting a 14 in if you have a trauma.
I've
the
only
average
seen
size
16.
is a 20, and trauma is a 14 to 16. So imagine a coffee stir as a 20 gauge, and a McDonald's shake straw as a 14.
Yeah, they're
What would
big.
that make a boba straw?
Like a 10. Yeah, like a 10. Or an
That's
IO.
a big ass straw.
Hell yeah, boba.
Yeah, boba straw. Literally sucking kidney beans up your colon. Disgusting.
That's more.
I had to. I'm sorry.
So go ahead and with every one of your patients, start an IV. There's almost no situation in which it's contraindicated. Okay, so even if you just start the IV via your interaction with these patients, just do it. And I'll tell you what, Mike and I, when we run calls together, it's great because we're always starting IVs, and he's saying things that I know what he's talking about, and I'm saying things that he knows what I'm talking about. So literally, if I want to, let me go grab. All right, Mike, you're my pincushion for the day.
I'll get the boba straw.
Oh god.
Use the 14.
Screw that. Ayo.
So it can literally be that simple, guys. You don't have to overcomplicate this topic at all. Okay. For people who maybe they want to enhance the situation and the interaction, they might say, well, I have small veins. That's okay. Go down to like a 22 or a 24. Okay.
Is that a butterfly needle? Which one's
So
butterfly?
get this. Yeah, get this. They're all the same thing.
Oh, cool.
Yeah, that's a little known fact. The only reason IVs feel bigger is because they're surrounded by what's called a catheter. Okay, it's a little piece of plastic that stays inside the vein and keeps the vein what's called patent. Okay, so that's the reason people say, oh, the only way they can get me is a butterfly. Well, that's just because they don't feel the catheter. So it's the exact same size needle though.
Cool.
But your average butterfly is going to be 20 to 24 gauge. 100% that is correct. Yep. When I draw blood, when I do what's called a straight stick, I typically will use the 22 gauge.
I just tell people that I'll close my eyes then, or it's my first day.
They love when I say that.
Oh, they freak out.
I love to tell them you're my first. Oh yeah, favorite color is a good one.
Remember the old commercials, the Holiday Inn commercials? They stayed at a Holiday Inn last night.
Oh yeah.
Yeah. I've done that before, and the older people just look at me and they're like, "Oh, you're not touching me."
So don't hesitate to start IVs on anybody. Don't worry about, oh, hey, I'm going to spike a bag, 500 milliliters normal saline or 0.5 dextrose or anything like that. Don't worry about any of that stuff. Just start the IV. Enhance the situation. Just that little bit extra. It takes you 3 whole seconds to do it. Okay?
I want to give him D10.
Hey, it depends on the
We're
patient.
not a diabetic emergency, or you could be old Johnny and Roy and give lactated ringers.
Oh no.
Okay, so last chance. Anybody? Any questions?
Taco, where'd you get that?
It was under the desk.
So is this going to be like a continued learning kind of thing where you guys host something?
My goal is to try to do one a month.
Yeah, that'd be cool.
Yay.
What I would like to do, Mike and I were actually just talking about it before this, and Mike, thank you for spearheading this. I think it's a brilliant thing you've done. So, claps for Mike here.
Yay.
Thank you.
Yay.
I think. Look at that, Mike. Hey,
I'm strong as fuck. God, let me put that down real quick.
As Taco breaks his foot.
There you go.
Not even clapping.
Throwing it around. Lightweight, baby, lightweight.
Next month, I really want to get into trauma. And then if you guys have any topics you want to go over, please let me know and we can incorporate them in there.
Yeah. What I was thinking would be cool to do as well. So I think what would be very neat is to have a topic that is specific to the city and a topic maybe that is a little bit more applicable to things out of state. So what I told Mike just prior to coming here is, hey, look, we're coming up on summer. How cool would it be to cover heat emergencies, heat-related emergencies? So that's an idea too. What we could do? We could start a poll. We'll start a poll about it and see kind of how everybody feels. Okay.
The corner of Legion Square where the 2 trackers are.
Great stuff, guys. Thank you.
We'll get someone over to you in a second.
Okay, I'll be staying around for just a minute. I'm gonna have to step outside of this building.
Sorry,
It's awfully bright in my eyes, but
We'll be around in a
I'll
minute.
stay around and I'll answer any questions. So the rest of you, I guess, thank you for being here. Thank you everybody for being here. Mike,
Somebody with
thank
a
you
bus,
again.
can you take that PD call?
Thank you again, Mike.
Not a problem. Who's got an ambulance? We can take that PD call.
Most of us.
Not
Oh,
it.
then
We can go outside the store and pick
Well,
one
no,
up.
Taco's gonna
Toes
come with
goes.
me
My
because
Corvette.
Taco gets to take his paramedic exam. Everyone, wish him luck.
Is what? Is paramedic dick exam? Is that what you said?
Yes,
I'm gonna get